So before Andreas starts, I'm Anita, we didn't meet in the morning, so I'm chair here now, and I would like I would like to invite you to tell us something about TEE.
Yeah. Thank you very much. I'm Dr. Andreou. I would like to thank you.
Do you need it?
No, it's fine.
Just
For
speak
the
up.
kind invitation, and also thanking the organizing committee for the invitation to talk to this Congress. So for the next 20 minutes, I will give a presentation about the evolution and clinical practice of perioperative transesophageal echocardiography. Before we start, I have a question for you. Is anybody an anesthesiologist here?
Yes.
Okay. And do you practice transesophageal echo? No, no. Okay, I will. Yes, perfect. So I have no financial disclosures. My only disclosure to you is you can relax. It is not about physics. It is so boring. And as you can see here, this is an editorial from a colleague from mine with Dr. Feroza in 2013 with a question, a new role for cardiac anesthesiologists. As the technology was already implemented, we are starting questioning ourselves, is that something new for us? We get to switch a little bit our role from service provider, and we have also new responsibilities. And if we want to put it all in one line, that would be that our role has transformed from service provider only to a decision maker in the operating room. And this is obviously a journey, a classic story of innovation, outpacing legislation. We humans, we like to make things and then figure out what to do exactly with them. And that is also with genetic engineering and 3D printing and artificial intelligence. So echocardiography was a technology that it was adopted based on common sense and evaluation rather than regular side effect, double-blind, randomized trials. And the founding fathers of echocardiography used, fortunately, implied logic for evidence and rationality rather than studies. And its clinical use and its values were established long before we established guidelines of who and where to use it. So the first steps of echocardiography in 1953, this was already a technology that was used for checking equipment, and Edler and Hertz borrowed this machine for a nearby shipyard and started experimenting in the weekend, making the first M mode. This is the first M mode that you see in the left corner with patients. And of course, they had no idea what they were looking at. So they were experimented with dying patients. And this view is also known as an ice-pick heart view. So when the patient died, they would stick an ice pick in where the probe was. And later in the post-mortem examination, they found out that this is actually that the ice pick transcended the anterior leaflet of the mitral valve. So that's good to know. To sum it up in a simple timeline, here you can see the technical advancements and the clinical advancements and implementation of the technology from the 50s up until now. So I have divided the history of echo into 4 periods: the 90s, the 2000s, the 2010, and 2020 onwards. Of course, there is some overlapping. It is not temporal rigid. And the first period is the period of the discovery and application and the service phase of TEE that led to the first echo war between the anesthesiologist and the cardiologist. We begin with Dr. Frasin. Dr. Frasin is now a professor in Chicago, but he was in training in San Francisco, and he was not happy with TTE, views. So he said, I'm going to try something, and I will do an esophageal stethoscope to get better views of the heart. But yeah, there were problems. It was very uncomfortable. Every patient was gagging. So he did an study with 38 COPD patients, and then he stopped. The second attempt was in 78, and what they did was an epicardial stethoscope. So it is not really a transesophageal, but Dr. Oka with his fellow, they made an epicardial stethoscope, but there were still problems. So there was an interruption of surgery. It was time consuming. They had to scrub up, and there was a risk of infection. And most important, the surgeons were not happy because they had to stop and wait 15 minutes for the anesthesiologists to do their thing. So the fellow, the Dr. Matsumoto, was not happy. So he was just get it over, and I will go back to Japan. And Dr. Oka, just to calm him down, he said, you know, when you start something new, you cannot always succeed. Just think of these guys in San Francisco, the transesophageal echo, what a problem that was. And that was the turning point for the perioperative transesophageal echo, because he said, okay, I'm going to try that. He bought the transesophageal echo, and he made the first publication for perioperative transesophageal echocardiography. And then the genie was already out, and the industry stepped in, and we have in 1982 the first 2D perioperative TEE. Jacques Saquet has done that. And if you see here, it was assembled in a gastroscope, but a good idea. And that's why our transesophageal echo probe looks like nowadays also as a gastroscope. Further advances is the pulse Doppler and the continuous Doppler, the biplane probes were capable of 180 degrees rotation. In 1992, the tissue Doppler imaging and myocardial strain rate. And this came very quickly as the industry was exploiting the new technology. And now that we have the technology, came the question, what are we going to do with the training? And the first training program began in 1992 in Beth Israel Hospital, where the cardiac anesthesia fellows were actually stopped with training, and they were going to cardiology clinic for 6 months as cardiology fellows to be trained in the TEE. And that led, of course, to the first echo war between the cardiologists and the anesthesiologists. And the question was, okay, now who owns the perioperative space? Who is going to implement this technology in the OR? Because at that point, it was thought, okay, this new technology is going to be a money-making machine. So it would be very good for the person who is going to do it. But unfortunately, that wasn't so, or fortunately, that wasn't so. And there were obviously some logistic problems for the cardiologists. They didn't like staying in an OR for 5 hours for a cabbage, or every 15 minutes telling the surgeon how the TR looks like. And they had other more profitable things to do, like studying TTEs for 5 hours for $200 that pay the TE. So, and also another problem was that the new technology, the TE, couldn't pay itself off because the cost of the machine was more than 250,000 euro or dollars. And they were billing the patient with $125. So it was very difficult to pay the machines. But it established very quickly its preventive value, which is establishing or excluding a diagnosis, expedition of management, and prevention of complications was indeed the greatest role for patient management. So if you are buying a TE to make money, now it's not a money make extravaganza, that's not going to work. But if you buy it to save money, that is very effective. So the war went on a little bit, and then we decided it's better to cooperate. And the National Board of Echocardiography was started, and they quickly splits the exams for anesthesiologists in 1997 and for cardiologists in 1996. So the cardiologists had the ACE exam and the cardiac anesthesiologists had the PTE exam. So this was really quickly solved. And then a little bit at the same time was the Council of Perioperative Echocardiography established, which recognized the role of cardiac anesthesiologists or the physicians in the OR as perioperative echocardiographers, and a formal collaboration started with the SCA and the SCE. And what is happening in Europe? Now, in Europe, things moving a little bit slower because we have a lot of lands, of countries. And in Europe, the EACTA was established in 1983, and in collaboration with the EACVI, which is the cardiologist leg, they developed 20 years later a certification in adult transesophageal echocardiography, which is an exam and also case reports with a logbook, and is renewable every 5 years based on clinical practice and CMEs. And of course, every country has also their own agencies, like the UK has a British Society of Echocardiography and their own accreditation program. And around the same time came the first guidelines for the use of the TEE. That was established in 1996, where the indications and contraindications were defined, skills, a level of expertise. And then a joint statement came from SCA and ASC, establishing what basic and advanced perioperative echocardiography skills are based on the number of examinations. And the basic is mostly regarded for general anesthesiologists, and the advances for the cardiac anesthesiologist. And in 1999, came this very famous paper for Dr. Sainwise, collaborated work from SCA and ASC. And this is one of the best papers for anyone who is inspired to be an echocardiographer, to learn all about the indications, standard views, what a comprehensive TE examination should include, and how should be reported. And there were further guidelines in 2002, 2010, and 2020, along with the latest modalities. Now comes the most exciting phase of the TE, which is the service role in providing information, and also the education phase, when we started educating anesthesiologists on how to do a TE, what are the applications, and how we can help. We entered the qualitative phase of the imaging, and people started helping and assisting in decision-making in the OR. And the first dedicated TE courses were organized firstly in the US, with most notable the SCA Echo Week since 1998 in San Diego, and then moved permanently to Atlanta, which was a 5-day course only for perioperative TE. And then there were also other congresses and sessions organized by SCE and as well as university hospitals. In Europe, we have numerous national TE courses, and since 2004, the ACTA Echo course, which is also a 4-day event organized every year in a different European country. And the 3-day course also organized for the EACVI. EACVI is dedicated to cardiac imaging, and of course, many courses from big university hospitals. Of course, now in the era of the internet, we also have other options. And specifically after the COVID epidemic, there are many courses and congresses which are digitally available. There are also many platforms in the internet, some free, like this fantastic virtual echocardiography from the University of Toronto. And in the digital era, and now everybody works with a smartphone, and maybe he's playing some games in the operation room, but we also have other uses. There are also many apps that are available, and they have largely replaced the handbooks in the operation camera. And at the same time came also the first simulation and the first simulation centers were created. And that was a very helpful thing for training the new colleagues, because it was confirmed with studies that have shown that simulation-based teaching is a better method of teaching the basic concepts of TEE, like anatomic correlation, structure identification, and image acquisition. So just to get the first idea before the colleague walks in the operation room, which is, the time is more pressing, and just get additional practice. Now comes the most important part, and that was the clinical application of the TEE. The category 1 indications are very well established: life-threatening hypoxia and hemodynamic instability. However, category 2 indications are not very well established, and it really depends on how good you are and if you have the equipment. And however, this remains an ongoing battle between cardiac anesthesiologists and general anesthesiologists, whether the TEE really makes any difference or not. The level of evidence of using it in cardiac surgery, other than open heart operations and congenital of aortic surgery, and then on vascular or high-risk non-cardiac surgery, is pretty much the same. However, when you ask experts and opinion polls, they say that TEE should be used in cardiac surgery, and for non-cardiac high-risk surgery, TEE may be performed, which implies it is probably a thing without training, a function of our training. And people who are well trained, they are most likely to use this technology, and people who are not trained, they're just not going to experiment during a high-risk non-cardiac operation. But the usage of TEE in cardiac surgery is widespread and well established. This is a picture in the USA where you can see the usage of TEE in CABGs. It is constantly increasing, and it's now around 60%, with big difference if you see here on the right in whatever the place or the state is, and probably if you look deeper between heart centers. For valve surgery, that the use is very high, is almost 90%. In the Netherlands, where I work, there is now a recent study among the 15 heart centers and 150 cardiac anesthesiologists. 53 of those are TEE accredited, and the usage of TEE in CABGs is above 85%, and for the indicated procedures is above the 95%. So we could say that it is a standard practice, mostly done by certified or people who just long enough practice it. Now, the third period of TEE is when the 3D imaging came into being. The quantitative echocardiography started, and we established the clinical impact of TEE. And here we can see on the left an anatomic schema, and on the right a video, what we now see. And the real impact of that was that we all saw the mitral valve like we saw it for the first time. The end-fast view of the mitral valve is standard now. We share the same language with the surgeons and the cardiologists, and that make a huge difference in the OR. We can now see pre-bypass the whole valve and communicate easily our findings with the surgeon. But it is not just, and this is the first article, the first publication by Dr. Lang in 2008, when he first used the 3D echo probe. And he said in 2011 patients, this is a technology, is very feasible. We have to implement it in our practice as soon as possible. And it's not just pretty pictures. We can now make quantitative approach of the geometric features of the valves. So now we are able to see, for example, that the mitral valve is saddle-shaped and measure exactly what is the height and what is the distance. the LVOT, we have found that it's not always a cycle, but more likely is an oval shape. And that had given us the opportunity not only to understand better the anatomy and the physiology, but also guide the industry to produce saddle-shaped rings for mitral valve repair. With the use also of software like 3DQ or MPR, we can now manipulate the 3D data and create the 2D views that we know exactly where they are cutting through, and we can make accurate measurements to help the surgeon decide how big the valve is, how big the annulus of the mitral valve is, for example, what is the length of the anterior cusp. We can also measure the function of the left ventricle or the right ventricle with almost the precision of the MRI. The last part now is the structural imaging, the interventional echo, and decision making, and of course the second echo war between almost everybody. So a lot of people, let's start with what is a structural heart disease. It is a non-coronary cardiac disease process, and we are developing interventional techniques. So if you look here, these are the percutaneous interventions, and they were pretty much basic until 2008, when the 3D echo came. And from that point on, they really exploded in the numerous interventions that we are now doing. So our role as imagers has put us in the multidisciplinary teams, like the heart team for transcatheter intervention. Our role was also maximized now in the era of minimal invasive surgery, where imaging is absolutely essential. Our services include not only confirmation of the diagnosis, assessing suitability, procedural guidance, establishing success, and excluding complications. Now, the new frontier for ONS is the intracardiac imaging, known also as ICE. And this is something that we will have to learn and to master and perform it. The image quality is analogous or the same as the TEE, and its use alone or as part of multimodality imaging combined with TEE is now the way forward for complex procedures. And with that, I have finished my talk. And these are the pioneers of the transesophageal echo and people who are still busy in promoting the technology here in Europe, but also in the States. Thank you very much.
So you're an anesthesiologist who does TEE during surgeries. For which kind of surgeries do you use it?
Now we are using
Personally.
yeah, we are using it for, I work in a heart center, so we are using it for every cardiac operation. We are also using it if it is necessary for TAVIs, because now we are moving to more simplified approaches for TAVIs when we are not using general anesthesia for TAVIs. We certainly use them for mitral clips and all the new mitral valves. And we also have a function because it is a general hospital, and we can make TEEs for the general anesthesiologists if they ask us.
So for which kind of surgeries do you use it?
No.
Non-cardiac surgery.
They can use it for emergency situations like hemodynamic instability for every operation. They can use it planned if they have a patient that they are thinking, oh, it is a little bit complex. Like, for example, for a patient with left ventricle hypertrophy, for vascular operations, big vascular operations, or big operations in general.
Okay. Thanks. Is there any other question?
Thanks for the presentation. Do you think that we use the by general anesthesia in no cardiac patient? So one thing, you use maybe this device with like a general anesthesia and surgeries. Maybe we will use it once or once per year. What do you think about that? Do you think that you, like cardiac anesthesiology, should go to do a difficult case like, for example, a transactional 20, 50, 100% thoughts with the surgery because cancer? So I mean, in that case, I think that's very important to follow research in collaborative. But I think that if we could have enough trainings, maybe I don't know if it's worth or not to use it.
Well, I think it's worth it, but you have to tailor it in your own hospital, because if you are working in a hospital with cardiac surgeons and with cardiac anesthesiologists, you can always try to cooperate. And if you have a difficult case, we are not doing the general anesthesiology lists. So they talk to us and we go just give them expertise over the echo. It's not like that we are taking their job and we do other than heart operation. So in the operation room, we stand with the general anesthesiologist. And it is always a question, if you are not trained, then you are not going to use it, even though you have it. And most hospitals, they don't even have it. So the first step is to have it, and then you can try to get the basic, like the diploma for the America, the basic echocardiography skills. And it's not the number is not that much. It's like 50 per year, just to be trained. And the data show us that we are using it standard for every heart operation. And what we are getting for the CABATs, it's not very much. And the data shows that it is the same with high risk surgery. But in the high risk surgery, it is almost never used, because exactly the anesthesiologist doesn't have the skill or he's not comfortable. But my suggestion is, if you have cardiac anesthesiology, you can always cooperate. If you don't, it is a question, okay, are we going to implement that for the use of it is very helpful in the ICU and also in the operation room and also in the A&E, the accident emergency. Just to exclude the diagnosis of establishing the diagnosis.
So maybe this will help. When you go to your vacation for 2 or 3 weeks and you come back, do your hands feel the difference?
No, it's no.
So
it is
it's probably okay if you use it one time per month.
Now, the technical skills are not very wide. It is only a question, do I feel comfortable just inserting the probe and, get an idea what I'm looking at?
Mm-hmm.
And of course, if you're not certain, you don't want to use it and, misuse it, or you can also cause a complication. So in that case, training, and that is exactly what the cardiac anesthesiologist, that we did it also. Training is important. You can go to courses, but you have to move forward in having the machine and, use it during an operation.
So probably we are safe because we won't get it.
Yes, I think that also in my case, my hospital, we have a cardiac anesthesia in the other building. So another center close to the main center, but it's not together. So I think if we have more space with the transthoracic echocardiography, in my case or my colleagues, we are more comfortable with this. Or with another devices like the outside or floor track, you can complete more information with those devices, and instead of to do the transesophageal echocardiography because not enough experience. So that is good for your side, but for our side, it's a general anesthesia. I find it very difficult to profit the.
Yes, it is always difficult, because if you talk about there is absence of results, of evidence. There is absence of evidence that that technology helps. But sometimes absence of evidence doesn't mean evidence of absence. Because if you are not using it, you don't really know how it is helping. And for example, not long ago, they had a patient, and you look at the monitor, you see a systolic pressure of 100, and they put in a Swan-Ganz catheter, and the pulmonary pressure was sky, and the CVD was also sky high. So the anesthesiologist said, do I have now, do I start inotropes? But when we put the transesophageal echo, you see a really, really hypertrophied heart, very good systolic function. It was just a diastolic dysfunction, so you had to give more filling. So the technology can be used with a Swan-Ganz and invasive monitoring, but sometimes it gives us just that extra information that is very important. Without it, they would start inotropes and they would see the immediate results, but not that is a little bit monitored treatment. But if you don't use it, you never know it.
So there is no questions?
No, thank you very much.
Okay.